And we're back with Taylor Goldberg for round two. Taylor's been, I was looking back at the time, almost 2 years. We recorded in 2023. For people who haven't listened, I would really recommend listening to that first episode because I thought it was great. Episode 89, all things hypermobility and upper cervical instability. Taylor, before we dive into the topic for today, for people who don't know you, can you tell us a little bit about yourself?
Hello, I'm very excited to be back. I'm Taylor. I am classically trained as a chiropractor, but I now work as what I call a fully virtual hypermobility coach. So I work with exclusively HSD and hEDS, which we're going to talk a lot about today. And I get to do that all through a computer screen, which is something I've recently become more and more passionate about, that we can give care virtually, especially for chronic conditions that do need a lot just more touch points than some of the general population. So I'm sure we'll hit on that too.
Yeah, let's just start with kind of defining terms for people who aren't familiar with these things. So HSD you mentioned and hEDS. Can you discuss really what those are?
Yeah, so HSD stands for hypermobile spectrum disorder and hEDS stands for hypermobile Ehlers-Danlos syndrome. What everything we're about to talk about is probably going to change. And I know I said this last time, but for real this time, the EDS Society is on a journey for 2026 to redefine both of these conditions. But as of right now, they are basically the same thing in terms of clinical relevance, especially from a conservative care standpoint. We're also going to be discussing a paper that recently came out. And one of the biggest things that this paper noted is the massive amount of similarities between HSD and hEDS. And so as of right now, think of them as the same thing. And so what this is it's classified as a genetic connective tissue disorder. Connective tissue lines literally everything in your body. And so because of that, a lot of what we call comorbidities can come along with this condition. We're going to talk more about that. That might not actually be the case, but that is where the current science is at.
Yeah, when I reached out to you again to have kind of an updated conversation about all of these topics, I wanted to hear your perspective of where to go with it. And you brought up this paper, and I'll just list it out. And I think it's still a preprint, but it's called Defining the Clinical Complexity of hEDS and HSD, a Global Survey of Diagnostic Challenge, Comorbidities, and Unmet Needs. And I think it's Taylor with a D, that is open access, but it's a preprint. So can you touch on why you want to discuss this paper, kind of an intro of what it is, and then we can go further?
Yeah, so it is a preprint. It is not peer reviewed yet. So let's just put that out there. But this is the largest study we have ever seen in terms of this condition by far. It studied over 3,500 people. I think it was 3,900, which we have never seen that large of a study in this population. So just the sheer amount of people that they were able to get involved is really the biggest reason I wanted to bring it up. And then the second is it confirmed so many things that people who work day in and day out with this population have been preaching and saying and asking about research for. And this just now kind of gives us data to say, hey, this is what we've been saying is real. We need to do studies on this. We need to dive deeper because honestly, the amount of data from now and when we first spoke 2 years ago, it really hasn't changed that much. And it's a big problem. And this paper also showed how hard this condition can be to live with. And majority of the reasoning for that is because they are very confused with what's going on in their body and they don't have a care team that's helping them understand that. And they feel very alone and isolated and hopeless. And if we could get some data to really change that, I think the quality of life of this population can really improve.
Yeah, so going into the paper, like you said, it was a huge group of participants or individuals within the piece. And again, it's a preprint, but it still provides a lot of information. What we can go down different pieces of it, but I know they spent a lot of time kind of diving into these multi-system manifestations. Can you discuss what they found and what that means?
Yeah, so I think the biggest thing, especially for physical therapists, chiropractors, occupational therapists, is that chronic pain is the number one symptom across the board. I think it was like 98% of this population deals with chronic pain. The other thing is that it is now confirmed 1 in 500, although we think it's more than that. But Prior 2 years ago, it was 1 in 5,000. So we are seeing the frequency more and more. And this means you are going to see people in your office that are dealing with this, whether they know it or not. So we need to learn about this condition. The second thing is that it is very, very multisystemic. And so you're going to need to create care teams and help your patients that are living with this create care teams around the multisystemic nature of their condition, as well as realizing that some of the things like the GI system and your neurological system are going to impact what you're able to do from a rehab setting or a conservative care realm as well. I think a lot of the time this patient population will get turned away because they're non-compliant or because PT isn't working, when in reality, we're just not looking at the whole person. Maybe they didn't eat enough and because their stomach hurts so bad that they actually can't exercise or they'll pass out. These are real things that happen in this population that I don't think we take in enough consideration when we're deeming somebody as not doing enough or non-compliant. And so that's the first biggest thing. And then the second, which I think this is going to be a huge topic for the future, is that we're starting to potentially realize this might not be a true primary connective tissue disorder, and the connective tissue component of it might be secondary. And so this paper really highlighted what we've all been seeing is that there's a predisposition to having a connective tissue disorder. And what you'll hear from patients is they'll say, yeah, I was living my life, like didn't think anything of it, didn't have any symptoms. And then something happened. And now all of a sudden my whole life is different and I don't even recognize my body. That's what we usually hear in this realm. And we're seeing now that puberty, postpartum, viruses like COVID and Epstein-Barr virus and these things can turn somebody who was once asymptomatic into full-blown symptomatic. And so that opens the question for, is this potentially an autoimmune disorder? And if it is, that's going to be treated so differently than if it was a primary connective tissue disorder. So this paper really, really opened the realm for that conversation.
So if it wouldn't be considered a primary connective tissue disorder, what things would be considered primary connective tissue disorders?
Marfan's syndrome, and then all the other types of Ehlers-Danlos syndrome. So there's 14 types of Ehlers-Danlos syndrome. This is the one that doesn't have a genetic marker currently. And there's been a lot of studies, I think I talked about this last time, trying to figure out that gene. And it is becoming more and more clear it's not going to just be a single gene. And there might be multiple reasons for that. And what they're starting to show is that there's subgroups in the hEDS population. So some subgroups might be a primary connective tissue disorder, some might be secondary to an autoimmune, et cetera, et cetera. Again, these are all hypotheses, but that's what we're slowly starting to learn over time.
We touched on this in the first episode, but it's good to circle back. The average clinician that's in an outpatient clinic, they see someone that's presenting with maybe a cluster of these signs and symptoms. They think, okay, there's probably a connective tissue component. Maybe this person has or has not been diagnosed with connective tissue disorder or hEDS or HSD. What is your recommendation for how clinicians can just start to navigate, like where to move forward? Do I treat and refer out? Do I refer out initially? It can feel paralyzing and there's so many different types. Where do you recommend individuals start if someone's initially just presenting to the clinic?
Yeah, I recommend starting with prioritizing their symptoms. So there's something called the spider diagram. I can send you a link to that. And it's just a very quick questionnaire that will show you, the clinician, what your patient perceives as their most debilitating symptoms. Because in this paper, it showed on average, we're dealing with 24 comorbidities per person. That's a lot of symptoms. And so seeing what symptoms are impacting their life the most, and if that is outside of your scope, then yes, the first thing I would do is refer. If that is within your scope, then I would start by asking ourselves, what can we do to get some relief? What can we do to improve the symptoms? And I like to, there's a debate on, is diagnosis important? Is diagnosis not important? I think there's a time and a place for diagnosis. And I do really believe it is dependent on the personality type of the person in front of you. If that person is the type of person that needs an answer to move on with solutions, they might need that validation before they're going to buy into what you're about to tell them. If they're the type of person who can work through solutions without that definitive answer, that's what I would recommend because that's going to be quicker and it's going to save them a lot of money. And this paper also showed the amount of time that patients are using to go to appointments and manage their care is over 5 hours per week on their own without any help. And the amount of money, it's pretty much all out of pocket. I think it was like 74% is out of pocket. And so this is a huge financial and time burden on this population, and we can help with that.
This may be obvious, but the things that we would pick up on that are outside of our scope, that we would make these recommendations for referral pathways and other providers, can you just touch on some of those things or some things they'd be describing with their symptoms and how you would navigate suggesting these other pathways or providers?
Yeah, so I would say the most common in this paper confirmed that is some sort of GI manifestation, whether that is they'll describe it as they were diagnosed with IBS or IBS like symptoms, and then gastroparesis is extremely common in this population. What that would be described as is like you feel like when you eat, you get abdominal pain. You feel like you don't digest food very easily and you can't eat a lot, or you'll be very, very tired or fatigued after eating. That's a huge one. And then also GERD, like any sort of reflux is really, really common in this population. And these things might seemingly like not seem like a big deal as far as a physical therapist or chiropractic treatment plan goes, but we know how important meeting our basic needs and meeting our protein needs are, and just eating enough food can be, as well as our relationship with food. It matters for how we're going to handle our care plan when it comes to a rehab program or when it comes to any sort of conservative care management. So I do think it's more important than we sometimes realize. So that would be the first. The second is anything in the autonomic dysfunction family that can be within our scope 100%. Especially, I know a lot of chiropractors do work with autonomic dysfunctions, but if you don't know how to deal with that, refer to somebody that does. And so what that would look like is dizziness, but not like vertigo dizziness, not when the room is spinning. It's more of like, I like to describe it as like a radio static feeling in your head. When you stand up, you kind of see stars, but they don't really go away. That type of dizziness. And it's usually going from sitting to standing. So it's usually not when you're just like lying in bed and that dizziness comes on. It's more of when you're changing positions that dizziness comes on. And those are good questions to kind of tease out. Is this more of a vertigo or is this more of a dysautonomia type of dizziness? And to be clear, you can have both at the same time. Some others would be pre-syncope or syncope in general. Having low blood pressure is very, very common. Brain fog, fatigue. And then for POTS specifically, which is a type of dysautonomia, there's like 30 types of dysautonomia. We now know is your heart might race really, really fast, especially doing something as simple as going from lying down to standing, or you'll hear walking up the stairs is like really, really hard for this population. Like I have clients that can like deadlift 300 pounds and they can't walk up the stairs. So if like you hear that, there's probably something in the dysautonomia family going on. And then now we're learning more and more about something called mast cell activation syndrome. And that is as far as diagnosis goes, a really, really hard thing to get diagnosed with. And so how I like to kind of talk about this is just your mast cells are angry, and that is going to drastically impact your treatment, as well as it can cause pain too. And so this paper also highlighted that the chronic pain experience in this population might not just be from the hypermobility, from the connective tissue component. There is a lot of other factors that might be playing a role in their pain story. And as we all know, pain is multifactorial, but more so coming from your immune system, coming from these other factors. And if we don't manage the mast cells, we can do all the right things on the other side of it, and they're still going to be in that same level of pain. And so that's going to be something that you're going to need an allergist or somebody who understands mast cells to help you out with.
The pain or chronic pain being kind of the biggest symptom that these individuals are reporting. And like you said, it could be influenced by a variety of factors or underlying things. Outside of kind of identifying some of those underlying things, is it for each individual, is it pretty person dependent if they can have, is it widespread body pain? Is it within specific joints? Is it fluctuating? How do they typically describe their symptoms or pain?
Yeah, I honestly see it as like there's subgroups is how I like to describe it. And so there's a percentage of this population that it is more like the fibromyalgia description of just widespread pain, doesn't really understand why it's happening, etc. And then there's another subgroup that it is very kind of localized to the areas that they have more tissue laxity in, and like their shoulder sublux a lot more than the rest of their body. And that tends to be the area that's causing them the most pain. This paper showed that the neck, shoulders, and low back were the most common areas. And then the third subgroup, I would say, is more of a like achy flu-like pain is how they like to describe it. And that to me is more of a red flag that they're more in that immune system family. And we definitely need to be prioritizing mast cells and potentially some other factors like long COVID, ME/CFS, post-exertional malaise in that subgroup.
That's really helpful to kind of tricate those for those first two, the widespread and then the second being maybe a little bit more localized. For those options or those kind of categories, what do you have from a suggestion standpoint for clinicians to start to work with patients on managing some of those symptoms?
Yeah, so I would treat this like you would any other chronic pain person. And the first step, I will say this population likes more education. I think we talked about this last time, but like a lot of general population doesn't really care about the pain science that us clinicians might think they do or want them to. I find that this patient population has been so misunderstood for so long, and the average for diagnosis, or not even for diagnosis, just for somebody to be like, hey, what you're dealing with is not in your head, is 22 years. And so this patient population has been looking for answers for a very long time. They're chronically online, and I don't mean that in a negative way. They're searching for something. And I think us as clinicians are doing a really bad job at making them feel bad about that. Like there's a reason they're online so much. It is not their fault that they're getting misinformation. That's our fault because there's so much misinformation out there. And instead of demonizing them, give them sources that they can go to that are good instead of just saying, stop being online. That's not really helpful for somebody who's really confused about what's going on in their body. Sorry, that was like a tangent. But so giving them true educational resources and a true understanding of what potentially might be playing a role, explaining the multifactorial aspect of pain, because when they're diagnosed with something like a connective tissue disorder, in their brain, everything is the connective tissue disorder's fault. And we kind of forget about some of the basics like sleep and protein and exercise, etc. Those things are just as important in this population as anyone else. And we can sometimes tend to blame it on, okay, no, it's just my connective tissue. It's just my connective tissue. There's nothing I can do about it. That's not true. And you need to be, as the provider, the one to tell them that. And then I would say asking them, how are they currently exercising? What is their relationship with exercise? A lot of this population is very fearful of exercise, and you will hear that they flare or get injured from exercise. Dig deeper. Ask them, what does that really mean? And a lot of the times you'll hear it's really that they're going 0 to 100, or they are not meeting themselves where they're at, and they're thinking they're where they were prior to getting sick or this onset of symptoms, and that really confuses them. Or it's really bad load management. I would say those are like the most common things I see. And then the fourth is nocivic interactions from other providers or from the internet is really, 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 really high in this population. And they will come to you explaining that they've seen or they've heard they shouldn't do strength training, they shouldn't do yoga, they shouldn't do X, they shouldn't. And so by being that person to kind of explain to them and to show them, hey, we can do these things, but be slow. Be very slow in this population. That's the other thing, is that wound healing takes longer in this population, and so does muscle mass development. And so having the conversation that don't compare yourself to your friends, don't compare yourself to your your peers. We are on our own journey, and it might take a little bit longer than you'd like. It might take longer than so-and-so. Try not to compare yourself. And then yeah, getting them on a good strength training program. I believe that's important for overall health in anybody, but especially in this population. And then I like to do something called flare tracking for my clients because there are a lot of factors that can trigger their pain. And instead of focusing on why that might be the case, we can use those triggers to create a what and how plan. So, what can we do for relief, and how can we make that accessible to ourselves? And having what we call a flare toolkit at all times so that they have confidence that, okay, if I do become more symptomatic, I know I can do X, X, and X, and that's going to make it less intense and less frequent. I've seen to be really, really helpful for this population.
Can you maybe provide an example of what that may look like of that flare tracker and then practically how they would implement that?
Yeah. So what the flare tracker looks like, there's an app called Guava that actually has a provider dashboard as well. So you as the provider can go and see all of your patients' data. It's great. They're awesome. They both have EDS and they're just a great company. So that's one option. Or what we have been doing for a long time is just create a Google form. Doesn't need to be super complex. And so in the Google form, we have our basics: sleep quality, protein, did we exercise today, stress levels, and then specific symptoms and what we label as warning signs. And so warning signs is something your body shows you before symptoms come on. And so let's use dysautonomia as a example here. If you notice that your feet are starting to turn that purplish reddish color, that's a warning sign that your the the label of that would be blood pooling. And when we notice blood pooling, that's our body's way of saying, hey, I need more support to bring my blood volume up. And the 4 ways we can do that is put on some compression, whether that's compression socks or abdominal compression, have some electrolytes or some salt in your water, lay down with your legs above your heart, and fourth, do something positive for your nervous system, whether that's gargling a glass of water, laughing with a friend, belly breathing. I'm not talking these $5,000 nervous system, vagus nerve things, the simple things. And those are 4 things that you can really do anywhere. And so that's one example.
Going back to the exercise priority or discussion and integration, is from the research, is there any suggested specific type of exercise routine, or is it pretty broad of they should be resistance training, they should be doing some form of cardiovascular exercise, hitting the physical activity guidelines, or is there more specific recommendations for this group?
I would say it's neither, unfortunately. So this has not been studied is the easiest way for me to say it. And the fact that it hasn't been studied and there is so much advice given to this population really irks me. But the advice that's usually given is to follow the Levine protocol, the CHOP protocol, or the Muldowney protocol, which are all extremely, extremely strict and very nocivic in nature and a very just too easy, like underloading your patients beyond a measure that should ever really happen. And so there is a large amount of this population that has gotten, unfortunately, really bad advice and is very underloaded and deconditioned. And we know the one thing that makes dysautonomia worse, it does not cause dysautonomia, but it can make dysautonomia worse, is deconditioning. And so a lot of this population is deconditioned, and we do need to help them become reconditioned in a safe, confident, positive way.
Like you said, the progression may be slower of how to integrate or add some activities or volumes. Do you have general kind of heuristics outside of maybe a slower progression of ways that you feel like have been more successful for these individuals? Obviously, there's a lot of variation, but just some kind of things you've learned along the way, either for yourself or for others.
Yeah, I would say the number one is we tend to do better with external cues than internal cues. That's something that I've been playing around with a lot more recently. And my understanding of that is we struggle with something called interoception, which is your body's ability to kind of feel what's going on internally in your body. And so what you'll hear from patients in this population a lot is when I'm doing an exercise, I don't really feel anything. Like I don't feel my muscles activating. I don't feel anything. And then afterwards, I'm in a lot of pain, like a couple hours afterwards. And a lot of the time that is because we are just speeding through our movement. So I would say tempo is the second thing to really, really prioritize, and going slower in your tempo. And then third, just teaching autoregulation. It seems simple, but explaining, especially to chronic pain patients who truly will have drastic changes in their symptoms day to day, but we can still exercise with our symptoms. We just need to know that it might not look like it did yesterday, and that's okay. And so I really, really emphasize using autoregulation with this population, and then teaching them how to modify their workouts on their own. Even if you are working with them from a virtual setting one-on-one, giving them the tools to start putting those pieces together for themselves is going to set them up for long-term success and sustainability with their movement practice. And then, like we talked about last time, proprioception is still a huge component. We do have slower or lack proprioception, which is where your body is in space. And that can look like we might go through our full range of motion without realizing it. And now going through your full range of motion isn't always bad, but if that's all we've ever done and we don't actually know how to control our range of motion, that's a good place to start too.
And then, like you said, that initial or one of the subsets of the kind of experience of pain group, that more localized, let's say it's their shoulder, they're have excess range of motion, they're hypermobile there, they have maybe recurrent subluxations or dislocations. One, there's contexts where there's this unstable shoulder, either traumatic or, atraumatic, but it's persistent. And then there's these camps where it's these recurrent subluxations or dislocations because of these connective tissue disorders. In that latter group, is a surgery recommended for an individual that's having recurrent shoulder or patella or other joint dislocation or subluxations?
So it depends. But bringing up the surgery conversation is, we need to risk versus reward for every person that's in front of us. But what we do know is that for things like labrum repairs, it is over a 50% chance that your labrum repair will fail in this population. And so that's something to be aware of. And as with any labral repair, we know that it doesn't always equate to symptom reduction or symptom improvement. And so that's important to note. And with surgery in this population, especially if we're dealing with some sort of mast cell disorder, surgery might take longer again to heal, and you might have more issues after surgery in other areas that might make it so that that reward of the surgery isn't necessarily worth it. Also, anesthesia reactions in this population are very, very different, and that this paper confirmed that, as well as pain medications don't seem to work very well in this population. And so that's also something that, although we're not prescribing or managing or monitoring that, it is something for us to note, because when your patient gets surgery and they don't have any way of managing it from a medication standpoint, that is going to make their chronic pain story different, and it's going to make them feel like nothing helps them and nothing works. And we need to take that into consideration when we're working with this population. That being said, I have seen, like, let's say with hip dysplasia, getting surgery for that can change somebody's whole life. So my answer is it depends.
Yeah, that makes perfect sense. Going back or circling back to the paper, what else do you want to touch on or dive into with some of your takeaways from this preprint?
I think the biggest thing is that we desperately, desperately need to be looking at these conditions more as physical therapists and chiropractors. Chiropractic was the number 2 sought out alternative medicine in this population, and you are seeing these patients day in and day out. You need to know what the differences are and how to recognize the comorbidities that are involved so that you can help this population, because you're seeing it. The other thing, like we already talked about, is that chronic pain is the number 1 symptom, and that is our bread and butter. So we need to know about this condition. Then some other selfish things that I thought were interesting is that the cardiac manifestations was pretty low in this study. And that has been an emphasis for all EDS groups, is go to a cardiologist if you get diagnosed. And I still do that, and I still will do that until the data truly shows otherwise. But we might not actually need to prioritize the cardiac system as much as the gastrointestinal system in this patient population, which I found really interesting. And so I'm definitely going to be considering that and looking deeper into that as time goes on. And then this is like the whole point of the paper, but we need an updated diagnostic criteria for this condition. The 2017 diagnostic criteria is garbage. I am confident saying that at this point. And 2026 is not that far away anymore, but we have to wait until then for that to change. And so treat these patients accordingly, even if they don't have a diagnosis, because the diagnostic criteria really is not great and it desperately, desperately needs to change.
Even though it sounds like it's trash, can you describe or discuss what it actually is right now? And do you have any ideas of what they'll adjust or evolve it into in a year?
Yeah. So right now it's split into three categories. The first is just the Baton scale, which we all know the Baton scale is a great quick screening tool, but it only tests 9 joints. And so if you don't have those 9 joints being hypermobile, and when 4 of them are in your fingers, then you just can't get diagnosed with this condition, which is crazy if you think about it. And so I think that's the first thing they're really going to change is how are we diagnosing generalized joint hypermobility? Because there is no criteria for generalized joint hypermobility right now, which I just don't understand. And then the second is a list of systemic questions, and it's 12 of them, and you need 5 out of the 12 for an hEDS diagnosis. I do think those systemic questions will change because right now they're really more towards the other types of EDS. They are not what we commonly see in this population. And this paper showed that as well. Like most of those symptoms are not what we're commonly hearing about from our patients. And then within that second category is basically, are you in chronic pain / do you have a family member that's dealing with this? Then the third part is where you need to get blood work done by either a geneticist or a rheumatologist. But this paper also confirmed that majority of people who go to a geneticist get better help. And that is to rule out all the other types of connective tissue disorders and any other rheumatological conditions or autoimmune conditions that might mimic hEDS. And that's how you get diagnosed with hEDS. Now, if you pass the first part, so you're hypermobile, and you are in chronic pain and have what they call a secondary musculoskeletal manifestation, that means a subluxation or a true medical, not chiropractic, or a dislocation, but you don't meet 5 of the 12 systemic questions, that's how you're now getting diagnosed with HSD.
Got it. And do you have any ideas of what that will evolve into with the new definition in 2026, or it's a waiting game?
I have my ideas, but it's definitely still a waiting game. I honestly think it's not going to be HSD and hEDS anymore. I think there's going to be multiple subgroups under hEDS, and I think those subgroups are going to be defined each by different systems, and some of them will be primary connective tissue and some of them are going to be secondary connective tissue, and I do believe there probably is going to be a subgroup that's autoimmune.
Going back to one of the early things you mentioned for working or interacting with this population is just the educational aspect and providing educational resources. I know on your website you have a ton of resources, but in general, do you have recommendations for clinicians on educational resources to provide to patients, or is it very, system or symptom specific of depending on how they're presenting and their chief complaints? These are some of the resources we can guide them to.
Yeah, so there's that, I will say, has changed a lot since 2 years ago when we first talked. There's so many more providers providing awesome, awesome education on all platforms. And yeah, Bendy Bodies is a great podcast to listen to. Disjointed is a good book. These are for patients specifically. And then I do have a resource page that is on my website. That's a good resource as well. Help I'm Hypermobile is also a good podcast to listen to. Potscast is a good podcast to listen to. And then in the mast cell world, Quiet the Diet is, they have a lot of stuff on mast cell activation syndrome. And those are good client facing resources for clinicians. I do now have a clinician course that takes you from diagnosis through a full rehab program and every flare in between. And it is now officially CEU approved in most states, which is very exciting. And this is the first time I announced that. So that's exciting. And then the EDS Echo program is also a very cheap, good place to start. Emily Richards Potts course is amazing. Those are some good clinician course resources. And then Courtney Jessimer has a Substack, which is my go-to for everything research in this realm. She like gives you little summaries. It's really, really helpful, and it's not that expensive. And so if you're interested in the research side of things, I highly recommend joining her Substack.
That was a lot. That was great. I think people could have endless time spent diving into those. And congrats on the course. We'll link that for sure. Since it's been 2 years since we chatted on this podcast, what within kind of your own practice or working with individuals or just in general, what has evolved for you, or if you changed your mind on with managing these cases?
Yeah, I would say, I don't know that a lot has changed as far as my mindset in working this population, but a lot has been confirmed, and which has been very validating. And I've just seen a lot more people in the past 2 years with this condition. So I think it's a multifactorial, treating like a biopsychosocial, focusing on the basics. Something that we didn't touch that much on, and this paper touched a lot on as well, is that sleep is a huge, huge barrier for this population, whether it's they can't fall asleep, they can't stay asleep. And so really creating good routines for this population can go a long way. And then again, if you're running into, you've done all the basics, you've done everything from a conservative care standpoint, don't be afraid to refer. And I think something that I have kind of, I don't know if changed my mind is the right word, but I do believe there is a time and a place for medications, especially when those medications are going to allow you to do more in your overall life. And like anything else, we need to take risk versus reward. But I think there's this movement right now that medications are bad. And especially in this population, they feel that because they were hurt by the medical system. And having that conversation and explaining that taking a medication doesn't make you less than, doesn't make you a bad person, and it doesn't make you unhealthy. We can use this medication to our advantage, and that can help us over time create a better health span and a better lifespan for ourselves. Because I would much rather somebody on a sleep medication getting good quality 7 hours of sleep than somebody who is getting 2 hours of sleep because they're scared to go on a medication and nothing else has worked so far. So I do think that is an important factor. My opinion on braces has stayed the same. My opinion on mobility aids has stayed the same. My opinion on strength training has stayed the same. My opinions on manual therapy have stayed the same. Not much has changed in that realm. And then I would just say emphasis on creating referral networks for yourself and creating a multidisciplinary care team. That is something that we do day in and day out. We create what we call one-sheeters for all of our clients so that they can bring these to their doctor's appointments and get the most out of their doctor's appointments. And that's been really, really helpful. Yeah, those are, I guess, it.
What is the one-sheeter? What does that look like?
Yeah, so again, there's so much that can go on with a patient. So they go to the doctors and they explain all their symptoms, and their doctor is looking at them like, oh, this is a complicated case. I don't really know what to do with this. I'm not going to, it's anxiety. I'm going to go away. And so we create what we call one-sheeters based off of their flare trackers. So we have the objective data, and how we go about this is the goal of the appointment. And we explain if that goal is accomplished, that is a successful appointment. We celebrate that. That's a win for us. If anything else comes out of it, great, bonus points. If that goal is not accomplished, then that wasn't a great appointment and we need to talk about finding a different doctor. Then next is symptoms pertaining to that goal. So not all of our symptoms, because that's going to overwhelm everybody there. So just the symptoms that are going to pertain to that goal. And that's what we get from the flare tracker. And then questions that we have for the doctor. And these questions are pertaining to the goal specifically, because sometimes we can get sidetracked and maybe we want these other symptoms to be looked at, but that's not what you're there in the moment for. And so just kind of prioritizing things a little bit better for the person in front of us and summarizing things easier. And when your patient gets overwhelmed very easily, which a lot of this population does, having a piece of paper where they're like, I forget what I'm supposed to be here for, or I can't really talk right now because I'm so nervous, they can just give that piece of paper to the doctor, which is also really helpful.
Yeah, that's really smart. Anything else with the preprint, the paper, or just in general that you wanted to touch on as we round things out?
Um, with the preprint, I just want to just emphasize that I think Sam was the other host that was on it last time, and I think we asked like, have you ever seen an EDS person in your practice? And he said no, and I would like to ask him that question again because I really believe every single clinician has seen somebody with this condition at this point. I feel very strongly about that, which just emphasizes the importance that we know how to help this population. And if you don't be afraid to say that. You're allowed to say, I don't know what to do with this, but I'm going to help you and find somebody that does and start creating those referral networks. This clinician side of things is growing. There's a lot more clinicians now that are focusing primarily on working with this population, and they're pretty much all on social media at this point. I would say that's a big difference from now and 2 years ago is social media. The noise and information that's out there right now is it's nuts. Like the amount is just absurd, and that can be both good and bad, but you can use it for good. And so finding good resources, good referral networks, there's a lot of online programs that this population can join and work through. So location doesn't have to be a barrier. I would say that's something that we haven't touched on that much, but I do think this population or any population that's in chronic pain or has multiple systems involved, having the ability to have everything in one place and having the ability to have somebody that they can reach out to and communicate with daily has been a game changer. I talk to my clients every single day, and when weird random things happen all of the time or there's so much information on their condition, they can just send that to you in the moment, and you can say like, hey, yeah, that's real, or like, nope, we're not gonna go down that rabbit hole, etc., as well as giving them just simple relief strategies that they can do in the moment, and hopefully that can give them some short-term relief so they can go clean their dishes, etc. I do think there is going to be more of that. I hope there's going to be more of that. I think it's really the new evolution of healthcare when it comes to chronic conditions. I think it's needed. And yeah, I think that's I don't even remember your original question, but yeah, I think that's it.
Yeah, you nailed it. I think this is a good place to stop. That was a lot of information. I think people have a ton of resources to go to. Again, they should listen to the first episode. They should take your course and dive into everything else. And yeah, this is great. It can still feel obviously overwhelming, definitely for the patient, but also for the clinicians. But like you said, knowing that there's so many support groups for the patients and for clinicians to have as really trusted other providers to reach out to communicate with or to refer out to if they don't feel like they have the adequate kind of skills or education necessary. There's a ton of people to help, which is great. All right,
Yeah.
Taylor, we'll call it there. Thanks again.
Yeah. Oh, yeah. I have one more thing I do want to talk
Yeah,
about.
totally.
So if you are looking to go into more of the virtual space, not hypermobility specific, we officially have a clinical mentorship under the Honey Badger Project, which the Honey Badger Project teaches you business skills to create your dream from a life design standpoint as a clinician, but also to get the best outcomes for your patients. And we are now merging clinical concepts and the Honey Badger Project together to create a amazing resource for chiropractors and physical therapists who want better outcomes for their patients and just don't know how to get there. And so I just wanted to bring that up as well.
Perfect. All right, we'll link that below as well if there's kind of a easier place for individuals who are interested to click and learn more. All right, Taylor,
Perfect.
we'll call it there. Thanks again.